Now let's think about the thumb joints. If I want to step up a step, and I'm not a physio, so I hope this is right. If I want to step up a step, I have to have a stable ankle, right? I have to have enough muscle power to stabilize that. I now have to have enough strength to stabilize my knee in semi-flexion as I raise my knee and extend it. And I have to have a stable hip in order to carry my body weight up that step. The thumb is no different. The thumb has 3 joints, and in order for me to distribute any power to my fingertip, I have to have a stable IP, MP, and CMC joint. I can never look at the thumb and not look at all 3 joints. So we want to look at the thumb as a whole, but knowing what each individual joint contributes and what it has in its ability to be stable or likely to be unstable is really helpful to us as we work through where's the major problem and how can I help influence this. Now, the 3 joints of the thumb are very unlike one another. They're dissimilar. They're constructed differently, they have different stability, and they certainly have extraordinarily different ligamentous system. But they all depend on one another. They work in concert with one another. So let's start with the interphalangeal joint. As we know, it's bicondylar, meaning 2 condyles, so it sits very stably, one bone in relationship to another. It flexes and extends, and it has very little side-to-side motion. So it is the only joint of the thumb that is built to be inherently stable. You can depend on the bony construct fitting together so that that adds to the stability. You can see here the distal phalanx base and the proximal phalanx head. You can see the concavity here and the convexity there and how it fits together. There is a really large capsule surrounding this joint, which makes it even stronger. And that is what creates the inability to have lateral motion in a normal thumb. Now, as we age and as our ligaments become more lax, it's not unusual for that to diminish. There is a proper and an accessory collateral ligament to the IP joint of the thumb. One, of course, is more stable in extension and one is more stable in flexion. But the interphalangeal joint of the thumb is just incredibly variable in its normal amount of range of motion. For this person, putting this needle through this fabric, interphalangeal joint hyperextension is essential in order to hold this needle. I worked with a surgeon, and in the operating room, he would take the needle holder and he would lock it by hyperextending his thumb and pushing on it. He was accustomed to that much hyperextension to put the pulp of his thumb on the instrument and have full feedback of where that instrument was. So many of us use the hyperextension functionally. But my question is, how many of us measure thumb IP hyperextension? Flexion is equally important because we cannot do any extremely fine motor task if we do not have interphalangeal joint flexion. We cannot pick it up. We need to oppose those fingernails. Now, if you look at this reference from 92, you'll see that the majority of us have from 50 to 70 degrees of interphalangeal joint flexion. Of interphalangeal joint motion, not flexion. That's flexion and extension, hyperextension together. But look, some people only have 20 degrees and some have as much as 100. So it behooves us when we are looking at an individual patient to always look at the contralateral thumb and to appreciate what is their norm. I, for example, have very little metacarpophalangeal joint flexion normally. You cannot then expect me to have more. But other people have more than 90 degrees. So it does become looking at the individual. Now, this is from Brand, and Brigitte and I were chatting this morning about, Brand is difficult to read. It's heavy stuff. But it is the single most important reference, I think, because he really understood the relationship of everything in the human hand. If you look at this, now this is a cross-section of the extensor mechanism and the FPL at the level of the interphalangeal joint with the axis marked. And you can see at the level of the interphalangeal joint that the flexion and extension forces are centralized and relatively balanced. Remember that, because we're going to move down, we're going to look at this again at the MP and at the CMC joint level. And what you'll notice is that as we move proximally, everything shifts away from being central to the axis of the joint motion. So now we have all these forces that are coming from different angles and different directions that make the stability of the joint much more difficult to achieve. So flexion and extension, we talked about measuring hyperextension. But the problem in that is the distal phalanx is actually curved. And by it being curved, it then creates a challenge for us to measure it accurately. So here's the thumb. And this is the way you would want to measure, but it's very hard to because there's a curve in the bone. You don't really know what you're lining up with. Well, if you line up that way, you miss a lot also because of the curve. It's just sort of everything's off on measuring the IP joint of the thumb. So to me, the single best way is flex the thumb at the top of the crease, wherever that top is. You can actually take a pen and mark it. That's your axis. Line that up with the fingernail. Now, that's not exactly precise, but it is repeatable so that you're measuring the same exact way each time you measure. I don't know of a way to be more accurate in measuring the IP joint of the thumb. Now, we talked about the collateral ligaments. This is self-explanatory that the proper collateral ligament being more longitudinal gives you more stability in extension. And as you flex, then the accessory collateral provides more stability. And that's very important because much of what we do, the IP joint, is in some flexion. Now, the volar plate of the interphalangeal joint may indeed allow you to hyperextend. How many of you can hyperextend your thumb IP joint? Okay. But then when you press on it and you push it back, you have a firm end. So the volar plate of your interphalangeal joint has a defined end to it, a normal volar plate. But as we know, any supporting structure over time or with disease can become elongated and not provide the stability needed. But defining what is normal for the individual is what we're about in looking at the thumb. I'm interested in, you'll see this afternoon, we're going to look at those individuals who volunteered. We're going to look at their thumbs. And one of the first things I'm going to do is to examine each joint. Because what I want to know is, I want to know of the 3 joints, is one or more than one really vulnerable to external forces? If so, that's the weak point. I know what likely we need to protect. So I'm going to be testing the side-to-side translation as well as the side-to-side motion of the IP joint of the thumb, and whether or not there's hyperflexion or hyperextension, just so I have a sense of how stable the IP joint is. The MP joint has been called a unique digital joint. It's really not a very great joint. It's a single condyloid joint, which means not much. There's this kind of shallow cavity, and there's kind of this curved bone, and they just sort of sit together. But we have now lost inherent mechanical bony stability. we are now dependent upon ligamentous support and muscular support for stability of the thumb MP joint. Unlike the IP joint, where we can depend on the bone to some extent. I myself, you're going to see an x-ray of my thumb later. On x-rays, my MP joint looks absolutely terrible. It's subluxed. I have absolutely no symptoms. But the MP joint can be the source of the problem, even more so than the CMC joint, but that is then what translates into the CMC joint having problems. My example is I have a total knee on my left knee, having had an attritional ACL rupture some years ago. And the only reason I had my knee replaced was I had gotten to the point where my knee was so angulated that my ankle hurt. Why? Because I was loading my ankle from the side. I wasn't loading it squarely. And that's exactly what happens at the MP joint of the thumb. It loads the CMC joint and it can create CMC joint pain, even though the CMC joint itself may not really have a lot of pathology itself. All right, we said the MP joint has a very shallow concavity, and that gives you very little intrinsic stability. But the thing that's so extraordinary to me is that if you look at the articular surface, now you would expect the volar aspect of the MP joint to have articular surface because that allows flexion, right? Right? Okay. And these are the articular surfaces for the sesamoid bones, which we'll talk about a little bit more. But if you look at the dorsum of the metacarpal head, you will see that there is also articular surface that moves dorsally, indicating that it's so easy then for the MP joint to hyperextend because there's cartilage available there. It says, come on, let's just come on over. So what is one of the most common problems we see in the thumb? And that is hyperextension of the MP joint. So we need to remember that. Now, the capsule of the MP joint is really complicated because you've got two sesamoid bones, which I have yet to figure out the function of, but I think it's just a way to provide additional stability for the ligaments, to give them something to attach to, so that force can be transmitted through them. But it's one big continuous structure, and the thing that's very different about the MP joint is that it's sort of similar to the MP joint of the fingers, and yet very different, in that it has multiple insertions of muscles coming through the capsule and going into the thumb in some direction. We'll look at that more as well. So here is this really complex capsular joint that has very little intrinsic stability, but it has a very big, strong capsule if everything's balanced. So it also has a proper accessory and phalangeal glenoidal, I can never pronounce that, phalangeal glenoidal ligament. So it has significant ligament structures to provide support and stability. On the radial aspect, meaning the side toward your radius, the flexor pollicis brevis goes into the ligament. And on the ulnar side, the adductor pollicis goes into the ligament. And the thumb MP joint is the most variable joint range of motion, more so than the IP joint. And you can see this. This was years ago. My hand's in the middle. These were 3 people in our clinic. And again, 40 to 60 degrees is most common. Yes.
I have a question about MP
Okay.
flexibility. When you see a ulnar collateral ligament injury in the clinic, of course you measure after injury, you measure always the healthy hand to have to set the goal for this individual person. And it is a feeling that persons with very little flexion in their healthy MCP joint, they are very frequent when it comes to collateral ligament injuries. Do you think they are, if you have little mobility in your MCP joint, you are more prone to have a ligament injury?
Oh, absolutely, because you have less flexibility. So when a force hits you, you can't go very far, and then the ligament has to give, and that's how you are injured. But if someone's very flexible, they take the blow and it's absorbed. I think there's an absolute direct correlation. I can't quote a source on that, but that it just makes logical sense to me. That it's true of, just look at the elderly. The older you get, the stiffer you get, the less flexibility you have, and you can fall the same way a young person falls, but the elderly person is badly injured and the young person has no injury at all. And I think that has a correlation in the same way, that the elderly person can't absorb, they don't have the flexibility anymore. Okay, so the MP joint motion can range all the way from 10 to 100 or to 90. And those of us who have about half of that, think of those who have limited MP joint motion, okay? And one of the scoring systems commonly used is the Compungi, where you touch the fingertips. You then go down to the base, right? You go as far as you can. Okay. Now, the demands on the CMC joint of the thumb during that motion is entirely different who has a limited motion at the MP joint versus someone who has significant. If I had 90 degrees of MP joint motion, I could reach that same point with far less CMC joint motion. So I'll be really honest with you. I have great difficulty appreciating the value of being able to do that. What is it I do functionally? And to me, that is an inappropriate exercise to give anyone, say, over the age of 50, because we don't need to be stressing the CMC joint to its maximum. We want to preserve it in its mid-range to maintain its stability. Now, the MP joint has several motions, not just flexion and extension, but it also has an ability to radially and ulnarly deviate. Now, that's normal, but that range also varies. I don't have any data on that, but the range varies of radial and ulnar deviation in the normal human thumb. And it also has the ability in many individuals to hyperextend. There is an accessory rotational component to the MP joint, but that is a very difficult thing also to measure. But some rotation happens, and it happens in concert with the other joints. One of the things we're going to be emphasizing is that no one muscle can be thought about in isolation when you're thinking about the thumb. It has to be the entire thumb working in concert. They're groups of muscles. And so as these groups of muscles rotate the CMC joint, many of those muscles also cross the MP joint. So they're rotating everything simultaneously. Now we've moved back down to the MP joint with Brand, and the FPL, as you can see, has started to move ever so slightly off of the central axis. But look how far the EPL, the extensor pollicis longus, it has now moved significantly toward adduction, has it not? And in a pathological state, the EPL is an adductor. If someone has ulnar palsy and they don't have their first dorsal, and you ask them to adduct their thumb, you'll see the EPL bring it over very clearly. So now we also have the EPB, but I don't, we'll talk about the EPB later. I have some opinions about it, so I don't want to skew your thinking before we get there. So there is simultaneous rotation at the MP joint when we pronate or rotate our thumb. So think of my leg again, and think of me turning my foot inward, and think of what happens at my knee and at my hip. It's no different. It's the same thing with the thumb. So we now need to think about that rotation occurring with everything. So it's very important at the MP joint to measure the contralateral, both flexion and extension, and I think hyperextension as well, because it's made to hyperextend. Not everyone does, but it is constructed that way. And I also like to measure radial and ulnar deviation, which in some cases of CMC osteoarthritis and pathology, with an adduction contracture of the CMC joint, the price that's paid is that the MP joint extremely abducts. I know you've all seen that in the clinic. And I do not know of a good way to measure rotation. We're going to talk about the opponent's polysis, and there's a little trick I have that might help, but I don't know that it's not a valid way to measure, I think. And that's what we're really missing, is our ability to measure that rotation, because that's the single most important thing. And remember that normal radial and ulnar deviation varies. And it's the same thing. You want to push on the ligament until you get a firm stop. You don't want to crank on it for all it's worth, but you want there to be a defined stop. That's the ligamentous boundary. And this is self-explanatory. We've been through that. Now, because the volar plate is often lax and because hyperextension is often present, I want to find the firm endpoint for MP hyperextension so that I know where the stop is normally for that individual. And then I also want to know whether or not the MP joint capsule is stable. So I want to do the translation motion and determine whether or not there's some slight subluxation of that joint. Okay, now we're to the most fun joint. It is considered the most complex joint in the human hand. And oh, how I wish I had known more about it when I started as a therapist. People call it a functional ball and socket because it has so much joint motion. Ball and socket, really stable, okay? You can move all around. There is no such stability in the thumb CMC joint. And because it has so much motion, the ligament structure has to be such to allow this motion, but that automatically means that the ligament structure does not provide absolute stability because it allows all this motion. You can't have both. You can only have one or the other. To me, the most extraordinary thing is the two joint surfaces don't match one another at the CMC joint. The base of the first metacarpal and the trapezium are not congruous with one another. They don't fit together. And because of that, we have no bony constraint. So we've got the IP joint with nice bony support, MP joint with minimal, and then we just lose it. There's none. So the human CMC joint is really totally dependent upon ligaments, ligamentous support and muscular support. The trapezium and the metacarpal base do not fit together at all. Therefore, there's just no inherent bony stability. So you're dependent upon ligaments, and muscular support. And we know as therapists that we can influence the muscular support. It's very difficult for us to influence the ligamentous support, but maybe not. We'll get there. Now, the first metacarpal that sits on the trapezium is 34% larger than the trapezium. That tells you right away they don't fit together because they're not even the same size. And you can see that they have different concavities and convexities, and that those also don't fit together. But because they don't fit together, there is an inherent bony ability when one bone moves that it rotates on the other. So there's intelligence in the construct, just not stability. And we all know that's the most common side of osteoarthritis, with the surrounding joints also occasionally being involved. And we've got this really incredible complex of ligaments that are impossible to evaluate individually. They can be evaluated grossly, and that's something we're going to focus on here. But there are 7. Think about that. This is one joint. There are 7 ligaments that support this joint. Can you name another joint that has 7 ligaments? Maybe the shoulder, but the shoulder really doesn't have a lot of stability at all, does it? It's totally dependent on muscles and ligaments. And then when we look at the trapezium being stabilized, there are 9 ligaments, because the trapezium is sort of floating out there. It's really not a very integral part of the carpal complex. It's sort of out to the side without a lot of stability on its own. Now, I'm going to go through these. I don't think you need to know them exactly, but you do need to know that there are dorsal ligaments and volar ligaments. And these dorsal ligaments are thicker, bigger, and stronger than the volar ligaments. So these are the dorsal ones, and these are the volar ones. The DAOL is the deep anterior oblique ligament, and it I would equate it to the anterior cruciate ligament in the knee, that it's inside the joint. Now, this is a schematic drawing that I have done, and I took the image of the trapezium, and I just put these all around it, took this from Zhang, to show you that the dorsal, think about these here, these are the dorsal, these are the volar, and this is the ulnar side. So these are the ligaments that keep it attached to the hand, if you will. And this is the flexion and extension plane of the thumb CMC joint, okay? So that just shows you a relative size of these. The DOL, because of the deep ligament, it was previously thought to be the most important stabilizing ligament, but that has been proven not to be true at all. It's very compliant, and so it's a poor stabilizer. It just kind of goes along with you. And this, I found this very interesting. If you look at the DOL here on these stained specimens, and you look at the dorsal radial ligament, okay? So here's the volar ligament, previously thought to be very stable. Here's the dorsal, now known to be provide much more stability. You can see that the collagen bundles are large, strong, well organized. Here, there's no apparent collagenous structure. So how could these have the same strength or the same ability to stabilize? So the primary constraint to dorsal translation. Now, when I say dorsal translation, you come down the thumb, you're on the dorsum. The first metacarpal moves dorsally, so it moves up this way, thinking only of the thumb, not of the wrist. It dorsally translates in relationship to the trapezium. So here's the trapezium, here's the first metacarpal, and it comes up like that. That is dorsal translation. Think of this as the metacarpal, my arm, and every time I flex to touch the base of the little finger, like we did earlier, I'm coming like that, and the force is for this to come up and out into dorsal translation. Does that make sense? That is the single most common cause of CMC osteoarthritis, and it is by far the thing we want to prevent. So what we want to prevent, more than anything, is this metacarpal flexing. And that is often a subtle, I'm really excited, one of our volunteers this afternoon, she has a really subtle presentation of flexion, and it'll be interesting to see if it's something that in our normal review, that you, normal examination, you would pick this up, that this is for her still a pathological problem that creates pain. Oh, the one thing I would like to mention as well is that I agreed to come and give this lecture, but I said to Brigitte, I'm not going to go through all of my slides and update all of the references. So I added newer references to your handout, but I did not, the slides have not been updated to the most recent references. We know that there is incredible innervation of these ligaments, and they're full of mechanoreceptors. I'm looking for one slide here. So there are significantly more mechanoreceptors in the dorsal ligaments. In other words, we get far more information about what our thumb is doing from the dorsal ligaments than we do from the volar ligaments. Now this is what I was looking for. Okay, these are 10 specimens, so each line represents a specimen, okay? And they were given a score as to how many mechanoreceptors they were able to find in the specimen. Are you with me? Okay, so if you start over here on the left, you're looking at volar and ulnar collateral ligaments, okay? And you can see that all of these specimens score fairly low in their mechanoreceptor ability. Excuse me, not ability, but the volume of mechanoreceptors. Okay? But you then look over here and you look at the dorsal and posterior ligaments, and you can see, except for this really funny green dotted line on the bottom that seems to be the outlier, they all have many more mechanoreceptors. So there is no question that those dorsal ligaments are what we want to depend on and what we want to allow to stay strong. They give us the proprioceptive information of what's going on with the thumb. Haggard and colleagues look at this as a synovial organ. I thought that was a wonderful statement, that it's so complex and it's so sophisticated that it's actually an organ that helps to support the thumb. But we have to have intact ligaments, joint innervation, and I am so disappointed that one of the things that currently is being considered is ablation of innervation of the CMC joint. I cannot understand how that's really helpful to moving a patient forward. The thing that we focus on is, and I want you to focus on the word reflex control. Reflex control of stabilizing muscles. We all know that the focus now is stabilizing exercises, but I'm going to challenge you this afternoon and say that there is sometimes a bit of a leap between stabilizing exercises and the ability to stabilize spontaneously, or if you will, reflexly, meaning in the moment. In the adult brain who's had an unstable thumb for many years, Brigitte is a perfect example. If she developed CMC osteoarthritis and pain, it would be very difficult for her to do exercises for a few weeks that have any meaning in terms of changing her motor pattern for pinch. And she would probably be able to do the exercises accurately when she was looking and thinking about it. But when she then gets in a situation where she's loading her thumb, the thing that's going to be most in the foreground in her motor memory is her old pattern of movement, not her exercise that she's been doing for 2 weeks. So that's what we're going to talk about this afternoon, is thinking a little bit differently about how we're going to integrate the exercises. We all know we need neuromuscular control. We know that when we land on our wrists, that our brain tells us, okay, stabilize those wrist muscles because here's the load of the body coming down on it. And we have a message that goes immediately. And that's what we want to key into when we are working to improve a patient's ability to use their thumb without pain. Do the ligaments vary in function? I think we're just on the very edge of understanding this. I think the human body is so much more sophisticated than we've ever given it credit for. The perfect example being thinking of one muscle contracting and doing manual muscle testing. Where did manual muscle testing come from? It came from the polio era as a way of diagnosing polio. And the idea of isolating one muscle and testing its strength, I'm sorry, but that's really kind of ridiculous. Let's just take the EPL. Okay, you test the EPL, but what's stabilizing the wrist while you're testing the EPL? The EPL is not contracting in isolation, is it? Lots of other things are stabilizing in order to allow the EPL a strong contraction. So I think we need to move away from that manual muscle testing sort of approach to the thumb and think more globally about what's happening here and how is it influencing these 3 joints. Now, the CMC joint is called a saddle joint. I don't know why. That is not accurate. It does not go in, it does not have one axis and go in 2 opposing directions. It just doesn't. It's not built that way. And a saddle joint would be very stable, and the joint is not stable. This is a more accurate depiction, the best one I can find, of how the first metacarpal has, if you will, almost a ridge to it. Here, you can see that there's a raised ridge, and it rests or glides along this valley in the trapezium. This is the first metacarpal taken off and flexed open, so you're seeing both articular surfaces. So this, you can see, cannot go straight across here. It has to go in an anatomically synergistic direction, and that is always curved. Now, just to make things more complicated, because they're, we've just now made them so easy, right? You've got the good IP joint there that flexes and extends. But on both of the proximal joints, you don't just have one axis of motion, you have 2. So the reality is, it's extremely difficult to measure the thumb accurately. How do you measure flexion and extension and know you're on the exact right axis? You just line up with the bones the best you can. So my question is, the way you measure, is it repeatable? To me, that's the single most important thing, because what we are concerned with as therapists is change or improvement. And if we can document that in an accurate way, then perhaps that's the best we can do. So when we flex, we adduct and we pronate. There's just no way around it. Try to keep your thumb abducted, abducted, and flex it. Can you flex it without adducting? No, because those muscles are working synergistically. And then the same is true of extension and abduction. And we then supinate, we bring our thumb up and around and our thumbnail more parallel with our hand. Now, the problem is that I get back to the terminology. If we're talking about the thumb and the thumb abducting, what are we talking about? Are we talking about all three joints are abducting? Or CMC joint abduction? Are we talking about, when we say flexion of the thumb, are we talking about flexion of all three joints? Or flexion at the CMC joint? And opposition, are we talking about rotation of the metacarpal or rotation of the whole thumb? Because each of these terms can describe either a single or multiple joints. So we cannot spend too much time being really clear with exactly what we're talking about the thumb. I think our terminology, I really think that would be a great future project for some group, would be to really focus in on thumb terminology, because if we can clarify that, we can then much better communicate with one another. Now, we're at the CMC joint. Look where the FPL has shifted to, and look where the EPL has shifted to. Both of them now are very much on the adduction direction, right? So as we are extending or flexing, there is an adduction moment arm at the CMC joint for those muscles. And the EPB and APL are also not centralized. They are much to the radial side. Just with that, just with these extrinsic muscles, that's all that's illustrated. We don't have the intrinsics illustrated here. Can you see how off balance the thumb is now? And the extrinsic forces tend to be larger muscles, right? Now, we don't have any defined procedure, but the thumb basically will go two directions. It will go dorsally and volarly, or it will go radially and ulnarly. So if you use your thumb and you stabilize your patient's trapezium, and you have to be very firm with this. Now, not hard and jerky and quick, but you have to firmly hold the first metacarpal. Put your thumb on the trapezium and try to lift the first metacarpal. Translate, okay, like that. You will be able to determine whether or not that individual's CMC joint has vulnerability for dorsal translation. You'll see if it's already loose. And yesterday, when I was looking at our volunteers, that's the first thing I did. I wanted to know, okay, do you have a loose CMC joint? Are you stable? Then you do the same thing in the opposite direction, meaning 90 degrees. You again stabilize the trapezium with, that's the red arrow here. And you have to really push your thumb down in that first web space in order to push the first metacarpal out at its base. Now, I would encourage you to take a minute. Find a partner, because you cannot do this on yourself. And see if you can be comfortable with these two, the dorsal translation and then the radial translation. Do it on maybe a couple of different people. See if it's different. It's gaining that ability to know when you have that firm endpoint versus, oh, man, that's lax. Compare their right and their left. Now, when you do this in the clinic, you will find that almost all patients who are lax will be lax dorsally. there are a few rare patients who will be lax radially. And if they are lax radially, your approach to their thumb must be entirely different than if it's dorsal translation. We're going to talk this afternoon mainly about dorsal translation and preventing flexion of the first metacarpal. Flexion of the first metacarpal, okay? Here's the base, flexion across the palm. But if someone has radial translation at the CMC joint, you want to prevent adduction of the first metacarpal, meaning moving the first metacarpal toward the second metacarpal, because that's what pushes the base radially out. Now, does that make sense to everyone? I want to be sure that's clear. Okay. So the recommendation is when you go back to your clinic, just walk up to everybody in your office or your clinic and say, I need your hand for a moment, and start examining the stability of the CMC joint and everyone around you, and get a sense of what is normal and what feels right. Because then you can so appreciate when you have a patient who has a lack of dorsal stability. You'll know the difference much more clearly.